The next person that we're going to hear from is actually a nurse that has been on the cutting edge of an innovation in the rural area. Her name is Briana White, and I'll let her take it from there.
Great, thank you so much, Nancy. I'm so excited and humbled to now share with you my passion, my innovation, the rural nurse-driven home care coordination model. And to build up Eric's presentation, I too think that there's no better tool to transform health than a nurse. So the problem is the population is aging, especially in Vermont and New Hampshire. The proportion of those 65 years and older is growing over time. Costs are also increasing as care is largely dependent on the unsustainable tertiary hospital system. Chronic conditions, or those who are living with comorbidities, are increasing, leading to more complexity and higher risk. In fact, 4 in 10 Americans have 2 chronic conditions or more. Rural residents also tend to be poorer, suffer from more chronic disease, and have a higher incidence of premature death compared to urban residents. Put all those together, and the problem is our older, sicker patients, especially in rural areas, are being hospitalized when care coordination could have prevented this. In fact, when I looked at the data to understand why patients were being rehospitalized in New Hampshire and Vermont, I found that the highest prevalence of rehospitalization occurred in home health patients, most frequently within the first 2 weeks following a hospital stay. Intervening sooner is key, yet geography in rural areas can make the timeliness of physical visits a challenge. Additionally, complex diagnoses such as oncology, cardiac, and renal top those patients who are rehospitalized. Many of those diagnoses, though, involve multiple specialists, medications, and for our rural patients, some who aren't health literate, confusion. Last, in a select cohort, 42% of patients who are rehospitalized would have been appropriate for a referral to hospice. So early coordination for appropriate goals of care is also important, and this problem called for an innovative solution. The Visiting Nurse and Hospice for Vermont and New Hampshire is the first in the nation to use a new care model of home health and hospice by employing clinical nurse leaders. Clinical nurse leaders are master's prepared nurses with competencies in care coordination, outcomes measurement, transitions of care, and more, and have been shown in the hospital setting to improve patient outcomes. This innovation used clinical nurse leaders to target patients who scored at risk for rehospitalization and deployed a telehealth intervention to focus on those areas and intervene quickly while coordinating care across the health system. Telehealth, or technology, in the hands of exceptionally skilled nurses and quality of care and the coordination of that care moved some mountains. The intervention spanned from connecting patients to a social worker, correcting medication discrepancies, finding resources for cost-prohibitive medications, educating on chronic conditions to which one caregiver said, "Thank you. You just told us in 2 sentences more about what's going on than the doctors have in years." The home care industry will soon transition to value-based purchasing, meaning fiscal rewards or penalties based on quality of care focused on preventable hospitalizations. This is the solution. CNLs have the skills and abilities to fill this gap and transform complex patient care in this setting and across all settings. Now, when you compare the cost of traditional Medicare reimbursement rate per visit for nursing care and multiply that by an estimated 48 visits, which is what we estimated could be completed in this 8-week span, that cost is only $9,600. In contrast, just one patient that is rehospitalized costs the health system $10,100. Further, if those 48 patients in that targeted 8-week time were all prevented from going back to the hospital from this coordination of care, that is a cost savings close to $500,000. Now, if the CNL intervention is even able to prevent one hospitalization, the cost of delivering those telehealth visits on time alone for those 48 visits is paid for in cost savings in the health system. Home care is the least expensive healthcare delivery cost out of all other options. Now add prevention of rehospitalizations with additional targeted interventions. This is where we need to put our funding. This is where we need to put our focus on. In parallel to being a Johnson & Johnson Nurse Innovation Fellow, I am also completing my Doctorate of Nursing Practice, or DNP, and I chose to study this innovation through a quality improvement project. And I'm excited to share some preliminary results with you all. So what did we learn? First, we ended up with 3 cohorts, each over an 8-week period of time. One was a pre-intervention group, the second was the intervention group, and the third we are calling control, where it was the same time as the intervention, but due to time constraints of CNLs, this was the group that didn't receive the intervention during this 8-week time period. What I want to point out is that yes, the intervention cohort has a higher rate of rehospitalization, 15%, than the other groups for the 30-day rehospitalization rate. However, look at the 60-day rehospitalization rate, 11% compared to 23 and 29% respectively. This can speak to the early intervention of the CNLs, alerting of complications early on, but making a drastic difference in the long-term 60-day time period for preventing of rehospitalizations. To put that into a cost perspective again, in the 60-day rehospitalization group and for the intervention group, you can take the actual 16 patients that didn't end up in the hospital, and that equates to $161,600 in cost savings over an 8-week span of time. The impact on nursing is that this innovation solidified that nurses belong in all spaces and places, and that certainly includes beyond the 4 walls of the hospital. The future of healthcare is home care. In the future, we're going to start asking, if we can do it in the home, why shouldn't we? We need to be able to meet the need of the least costly care option in the most desired setting for healthcare for patients. Finally, the CNL role is skilled in breaking down silos, coordinating care with an eye on quality, investing in innovating in nursing roles outside of traditional settings, invest in the spectrum of care to improve health. So the future is bright and busy. First, I am honored that our team, myself along with our home health CNLs, Jenna Parsons and Sarah Little, will be presenting this work at the CNL Summit in February. Next, I am helping to lead Dartmouth-Hitchcock Health's first nursing hackathon in April. As I told you before, I've worked towards my Doctorate of Nursing Practice along this fellowship and will be graduating this May with intent to publish this work. From there, value-based purchasing, shift, and home-based care is going to transform our industry, and I hope to help lead the VNH in this care delivery model on demonstrating the needs for CNLs in this era of healthcare and home care. Finally, our team, in addition to 2 home health CNLs, also has a hospice CNL, and we are just in the beginning of collaborating with the health system and other CNLs and colleagues. But I am watching those silos be toppled and care just on the precipice of transformation, with clearly already some big initial outcomes on what we can do when we focus on quality and empower our nurses to create the solutions they know patients and families need. I need to express my sincere gratitude to everyone on this slide from the leadership team for saying a resounding yes when I came to them with this idea, to the frontline team, my team put in an incredibly hard amount of work, to Nancy especially from Nurse Approved by keeping me in line and focused despite my never-ending ideas, to the Center for Creative Leadership in Johnson & Johnson, my UNH mentors, my family and friends who would watch our toddler when I would have just another meeting, and my J&J NIF fellows who become like a family to me. I want to share these words from Ralph Waldo Emerson to continue this theme. Throw a stone into the stream, and the ripples that propagate themselves are the beautiful type of all influence. So JJNIF colleagues, continue to be the stone, inspire those ripples. We will never know how far they will travel. Thank you. I'm humbled to be at the end of this presentation that was 2+ years in the making. And with that, I welcome any questions, comments, or ideas you may have.
Oh, thank you, Briana. That was a great presentation. And knowing your work quite well, it just barely covers the surface of what you have done in the past 2 years. And that you're getting your DNP, your Doctor of Nursing Practice, and that you're going to be in the conversation about value-based care and payment is really an incredible contribution. And I know you've got a fabulous team that works with you, and I really have had the privilege of working with all of you. So, you know, the couple of things that stuck for me was that you really have been heavily using televideo for the delivery of services, and that has played a big part into what it is you've done. And it's across the board. There's no question that the pandemic has increased the use of telehealth. Do you think it served as a catalyst to permanently expand the telehealth services?
Yes, that's a great question. I would say that there's this misconception that people in rural America don't have access to technology. They certainly do. A telephone is a piece of technology. So we're just, again, on the precipice for exploring that. And this is really only the beginning. So it's been absolutely a catalyst to continue to explore different modalities.
Thank you. The other question I have for you, I know that you've talked a lot about using data and data analysis in your work as an integrate part of what it is that you're doing and guiding the practice. Can you talk a little bit more about that?
Absolutely. I would say in home health and hospice, we are privileged that CMS actually, through a lot of our mechanisms, collects a lot of patient data. So we have a lot of data to work with at our fingertips. Sometimes from my experience, even more so than the hospital or the ambulatory care setting. So we have this opportunity to be able to use that data and make sense of what we're doing. And I think as value-based care continues to transform the industry, that's going to continue to be more and more important, and we're going to be looking for nurses that have expertise in data analysis and healthcare.
And the other thing that I called to mind is Sue Hathmiller talking this morning about really bringing in the cost when making studies and making cases for making change happen. And I know you've got a strength of that on your team. Can you talk a little bit about how you've done that? Because you had some great numbers in that presentation.
Absolutely. So again, I'm very honored to have an amazing leadership team within BNH. Our CEO actually has an MBA, so she's really helped me look through the finances and make sense of it all. I think there's opportunities to use that as a tool as a nurse to leverage your idea or your solutions. And I think there's also leveraging in that. As of right now, home health does not reimburse nursing telehealth visits. But as you can see from the presentation, I think there's merit in exploring that. And I know there's talks of what that cost savings is to the system as we move towards value-based care on the national level and the legislation.